Karen today, she picked up in the morning the word more. So I turn it around and say less is more. Less really is more, and I will show you a little bit. It was 100 years we needed to come to minimal invasive surgery. 100 years. It was in the 80s, I was in school. Many of you maybe were not born. Some of you were starting their medical career, and they were at the point when minimal invasive surgery came in. So we will have a look, who of us needs another 100 years to get the next step, which maybe is single port surgery. And this was not only true for cholecystectomy, but for all procedures intra-abdominal, like colon resection. And you see the difference, of course. And it means putting in 2, 3, 4, 5 or more ports into the abdominal wall, and also in the thorax, wherever. And it became the gold standard for a lot of procedures. And that's proven. And it was not proven when they invented it, but it was proven 10, 12 years later. We know now all these lists: less trauma, less pain, faster recovery. They go home, they feel well. If anything goes right intra-abdominal, they have less adhesions. We can do the same in oncological resections with the same long-term result, which is very important. It should not be worse. They have less incisional hernia, and if they have, the problem is smaller, of course, because the incision is smaller. It is, in most cases, a blind approach. So we put in the varus needle, we don't know where we are. We have some trocar injury. We have, of course, trocar hernia, and maybe, even if we call it keyhole surgery. I'm aware in Austria and in Switzerland, and as I found out in the Netherlands too, most doors do not have more than one keyhole. So I put a question. They all have just one keyhole. So is this keyhole surgery? Well, actually, the most keyhole we use to go is this. And in the end, as you see in this picture, the last keyhole to a door to heaven, maybe it's single port. So actually, single port is the way we go. So I'm finished again. We have another 10 minutes. Okay. Can we do it in this procedure? And Harry, I have a question to you. I know your wife prefers the way to go, but which of those 5 would you choose for your wife? Okay. Thank you. No, I go again. Can we reduce the incisions? Can we use natural orifice to achieve this result? And can we avoid any visible scar? Is this possible? Yes, it is. And you know, we are easily satisfied in Austria and Switzerland with the very best, and this probably is the very best. 2 ways: single port, and it started in the 90s. It was appendectomy first. It was not what we now call, or what we do as single port, because it was just mobilization and put it out via the umbilicus and make it open. But Navarro was the first, end of the 90s, to put a lot of sutures in, and this was difficult. This is not the way we do it today, but the ideas go back to the 90s. And then there was another idea, natural orifice. We put in a gastroscope and then we can operate everything. Well, if you talk to the gastroenterologists, yes, we can do it transgastric, transrectal, transvesical, transvaginal, but maybe this is a keyhole, we don't see anything. So this is, in real, pure nodes is maybe rather that, while single port is a possibility. We can do a lot of things, very nice. And only Zornig, he showed with the transvaginal cholecystectomies, it's in a hybrid nodes technique, that it's possible to do some things without visible scars and use the vagina as a specimen retrieval place. Okay, always if we put in new methods, we have some concerns, and you know I'm one of the first. Erich Mühe, I showed him, he was the first to do a cholecystectomy. He was thrown out of the surgical community in Germany. Hopefully, I was just thrown out of Austria to go to Switzerland and work there, and it was not really thrown out. But some years later, in 1988, he had the greatest honor from the surgical community, because everyone realized this is very good what we do, and everybody of you is doing minimal invasive surgery. So the concerns were, is this safe? Is this just fun for surgeons, or is it really safe? And have we more complications, and what are we doing with our patients? So, is this the way we want to treat our patients? We should really know what we do, because maybe this is somehow hard. But single port surgery, I show you, it is known, it's minimal invasive. So the indication, the relative and the absolute contraindications, and even the OR setting, it's the same. We're used to that. It's the same as in laparoscopy. And if we need, we can easily convert. It's not a problem to put in some other trocars. If we can fill the whole abdomen as much as we have on the table. We can do that. So this is known surgery. It's not the same, but we are very adapted to it. The second thing is, and this is a big advantage, it's always an open approach, and we have always a protection foil. Imagine how easy to bring it in, especially if we have adhesions after open or laparoscopic surgery. And look at the picture. If you put in your first trocar and you see this, so, well, we don't have any good feeling about that, what we see. And even if we see it, the question is, where do we put the second trocar to make adhesiolysis? So look at this nice and fine trocar placement. No injury, because we just put it in the system. And then we close it, we can insufflate, and then we can operate. And if we want to put in a big mesh, if we do single port IPOM, we put in a big mesh with a 10 millimeter trocar, a big mesh, it's not possible. But you can easily do it, and you have a protection foil. And if you want to put out the specimen, you have your protection foil. It's easy to do, and we all waited for that. You just put it on again, and you operate again. So it's quite easy. You don't have a big hole where you put out the specimen, you have to suture it, air leak is going, you just continue your operation. The next thing was instrument handling. Look at me, of course, in the beginning, this was, everybody said, you have to cross your hands, it's not possible to work. But look at that. It's easy if you know how to do. And it's the same if when they started laparoscopy, the first cholecystectomy in all hospitals were 6 to 8 hours. It was looking horrible, and everybody said, instrument handling, you cannot do that, you are not allowed. But you see, it's possible if you know how to do it. And of course, there are studies, not that much that we need already, but those are 102 studies together. And they showed conventional laparoscopy is equivalent, low and similar complication rate, less wound infection, maybe because we always have a protection foil, and they have less pain. So it is proven already a little bit, this goes the right way, this is safe. And I just show you, there are some registries. I just show you the Austrian because I run it myself. And we had last year in August, we had over 4,000 operations in. So that's a big caseload. Of course, that's not randomized study, but we can show what did they do. There were over 40 hospitals participating, and they have intraoperative complication rate of 0.7 and conversion to open 0.6. So that's very low. And we had over 90%. We could finish in single port technique without any additional trocar. So this is shown already, it is possible, and it is safe and has not more complications. The next concern we had was everybody, in Austria, there were bets, everybody will get an incisional hernia and everybody will have wound infection because we stay direct in the umbilicus. And we looked at that, if this is true. Incisional hernia, you know, just one of those who are published in laparoscopic colorectal surgery. After open, it's very high. After laparoscopy, it's about 7.2, and most are where the specimen retrieval was. But 1.2 is at the port site, 10 millimeter, 5 millimeter. And 20% are at the 5 millimeter trocars. So it is not zero. The related costs in Germany, 128 million euro a year, incisional related costs. So the best thing would to be avoid any incision. That's nodes. We know pure nodes is not possible, but that what we do is similar. And this is another study which showed up to 4 centimeters. We stay above 2% of incisional problems. What we do is if we make the incision right in the umbilicus, we find a lot of umbilical hernia. About half of the patients have a little hole. So we close that immediate. And the second thing is we measure, and our fascia incision length was about 2.3 centimeters, starting from 1.6, which is very important if we just don't put out anything. We make a hernia repair. We don't put down anything, so we should stay as close as possible. And 1.6, that's the outer diameter of a 10 millimeter trocar. You need a 1.6 centimeter incision. This, you can make that in mathematics, that's easy. It's 1.6 centimeters. And then we had, from the hospital where I'm coming from, when I left, we had 1,400 operations there, and the first 1,100, we looked at them after 6 months. What is the problem with hernia infection rate? And we saw it's 1.4 and 1.1. So it's very low. Not everybody got it, and it was up to 3 years from 6 months, over 1,000 patients. We showed it's not more. So we can make a minus here. The next thing is cosmesis. Is cosmesis important? Well, maybe not for all the patients, but first you said nobody of you want to have scars, visible scars. Is it a thing I can challenge you? So I have 5 patients with 5 operations. 4 are operated, 1 is not operated. And please, can you tell me, Harry, who had which operation? If you know it, you are invited for dinner.
That's difficult. I think on the left side it's not operated. Do you see the scar?
The left side, so this one is not operated, yeah, which is lying on the UR table. Thank you very much for the...
What species is this? Is this a human?
This is human. This is not a pig. This is a human. He is lying in the UR. So, Ottmar, do you have any idea? Which is operated?
The one in the middle, on the lower, no, the one below.
He's not operated? Okay, which had the pancreatic resection?
Second to this?
Yeah. If you know all.
Okay, you're right. Okay. The pancreas. I think it's the one in the middle on the upper one.
This one? Okay. Harry, another try? This one? Pancreas? Yeah. Okay, let me tell you one thing. Of course, you're wrong. Yes, just with one patient. This is just different kind of photo. This is on the OR table. This is 2 days afterwards. This is when he left the hospital. This is 3 weeks later. And this is probably after 1 year. Everybody looks like this. So we can imagine cosmesis. That's possible. And it is a proven benefit that it's substantial physiological benefit if you have nice cosmesis. And this was looked at 1 month after. Now you can say 1 month. What is 1 month? But the same group, and only if they were operated in single port was a difference. He looked at them 1 year afterwards, and especially after 1 year even, it was single port surgery that they felt much better. Okay, now you say, if we put out the colon, how can we have nice cosmesis? Well, we can actually. Of course, if a tumor is 5 centimeters, the incision will be more than 5 centimeters. There will not be any other possibility if we put it out transabdominal. But we can use other routes. We can go transvaginal. And we know the head of a kid is about 10 centimeters. So probably we have up to 10 centimeters placed there. And we can go transrectal. Of course, we can do 10 centimeters, but we have the sphincter. And maybe we should not do damage, because this could be a greater problem. I'd rather have an umbilical hernia than a sphincter defect requiring much more operation on that. So, of course, now everybody is concerned. The women are concerned because they are the women, and they have a vagina, and men are concerned about their women. So just... Every time I get the same question. Can you talk to patients and tell them this is a good way? Would you have operated on your wife? And I tell you one thing. This is a pain-free zone. We do a posterior colpotomy. It's pain-free. There are no nerves at all. This is natural good healing. Mankind would not have survived if there would have not been a very perfect wound healing. And it's easy to close. If you have ever done a transsphincteric operation, transvaginal is quite easy. That's because gynecologists do that, because it's easy. And they didn't do it yesterday. You know when they did it the first time? If I give you the question, women all in the room, would you have been operated by a gynecologist transvaginal? Everyone would say, yes, of course. And they started it 150 years ago. So there's a lot of evidence that this is perfect. It's a perfect route. Actually, Most of us came through this route on the earth. They only, with single port surgery, some were fetched out, but the others came transvaginal. Okay, and transrectal, of course we can put in a port. That's the one thing. We can put out polyps. It's perfect. It's much better than 10. I'm not allowed to say. But this is quite good. You can do anything. You can do real laparoscopy. But also you can put out specimen. And this looks like this. And of course it's more than a flatus. But it doesn't hurt more than 2 or 3 hours. Whoever has flatus hurting more than 2 or 3 hours, maybe he has a problem on the sphincter. But this is possible, and we can put it out. And also we can operate via the ileostomy. Put the single port system here. So this is in the beginning of the operation. This is the end. What is between? We put out this specimen. And where did we put it out? Transrectal. So it's possible. If we want to do that, and in the end, she has the only incision we need, because we do in double loop ileostomy. So the next thing is cosmesis. It's possible, even if we put out the spleen, we can put it out transvaginally. Why not? So this is a sad talk. It's not a sad talk, it's a sad talk. So of course I have to say a little bit about education and learning curve. Everybody heard enough about education and learning curve. But if you look to history, all procedures deal with this question, and they started, even if appendectomy was the easiest one, so the gynecologist operated it at first. The cholecystectomy was what everybody did in the first place, and everybody was looking about that, and they were happy to come from 2 hours to 80 minutes within 100 cases. We know 100 minutes, that's a long time. We don't expect 100 minutes for a cholecystectomy. We don't expect 80 at the moment. So you need training. If you want to be on top, you need training. And you can do that. There are a lot of possibilities. We heard of that. And of course, you need a trained trainer, teach the teacher, teach the assessed, whatever we heard today. If you have that, then it's possible that you make real good on top in between short cases. And if you look at that, what was published for single port surgery? There's one saying you need 5 cases. Another says you need 20 cases. Another says you need 25. Well, actually, what we think is for all minimal invasive surgery, you deal about 40 to 50 cases, and that's if you do minimal invasive or you do single port, that's the same. That's the number you need that you know what to do. And we looked in our learning curve in TAP procedures in our hospital, and you see this is what we see. Reinhold Bittner published that. Normal TAP, you have 34. After 34 procedures, you know how to do a TAP. And we see we have the same. The intermediate phase is about 35 to 40, and then you know how this procedure works. And the same in single port like in normal. And in appendectomy, we looked on my senior consultants, their first procedures, and we don't see really a learning curve because it depends how difficult the case is. So there was not really a learning curve. They adapted immediate. If you know how to do laparoscopic appendectomy, they adapted it. If they know how to bring in the system, then they could operate it. So there was not really a learning curve. And I looked on my residents. And one of those curves are the residents, and one of the curves are the senior consultants. Who can tell me which curve is the residents and which curve are the senior consultants? You cannot? No dinner today? No. So the senior surgeons are the gray ones, and the juniors are the green ones. And you don't see a difference. So we have to go on. And then that's it. I'm ready. This is what we did. So we're talking about experience. And if you make new things, we want programs, but we don't want change. Mark Twain said this. And if you want to have progress, maybe you always did this way up. I'm coming from Austria and Switzerland. Of course, we are skiing. If you always go the same way up, you will have the same result when you go down. If you make another route, maybe it's more difficult in the beginning, but you will see things you've never seen before. You will have followers who come after you, and you will like it extreme. Thank you very much.